We are talking this afternoon on international perspectives of clinical diagnostics. And we had a guiding mail from the moderator which said, the world is flat. So do those international perspectives translate into direct applicability to different countries? My take on that, and that's my starting point, is a big no. Let's not forget that science and technology must answer the aspirations of the public and the society. Science has to develop in tandem with the requirements of the society. Therefore, all international perspectives cannot be translated to our use. So what is holding back the technological, what shall I say? It's been a big evolution and a sudden outburst of technology. But has the human resource developed paru passu with the technology? There is so much of gap. Does an average man on the street know what a SPECT and a PET scan is? Therefore, as we develop technology, we must also evolve our human resources and get them in the equivalent terms. There is a big gap in the knowledge base. Do we have any epidemiological studies? Do we have any data of how much disease processes are existing in this country? We must get our priorities right. We don't have, none of the national bodies have any registries and authentic databases. Also, the technologies available to us, have they been evaluated properly? All of them, we say Tesla 3 and Tesla 4.5 machine. I can see 1 millimeter of a nodule in the chest. Has anyone presented data that this changes survival statistics? Has a technology been assessed based on clinical outcomes? The answer is a big no. And that needs to be done. We need technology which alters clinical outcome. We all know Ayurveda is such a wonderful field of medicine. Doesn't work in America. Why? Because what works here may not work there, and that's what brings the importance of things like pharmacogenomics. Biomarker research is of utmost importance, not only in clinical care delivery, but also in drug development. We were talking of cost reduction. We can use these technologies. For every 10 to 15 drugs that start off from the baseline, only one sees the end of the tunnel, is brought into clinical use. And if we can use biomarker technology and maybe in stage 1 and 2, say this drug is not going to do well, the go and no-go decision, we may be fine. Similarly, pharmacogenomics may be used. Someone talked about drug interactions and adverse drug reactions and mortality occurring directly iatrogenic from drugs. Almost 5/5 of the mortality is drug-related. So pharmacogenomics can help on that. We have to identify priority areas. There was an Indo-US workshop just 2 years back on low-cost diagnostic and therapeutics, where exactly today's topic has been thrashed out in details. What we need is low-cost sugar monitoring. What we need is prothrombin kits. What we need is depot penicillin. What we need is depot insulin. What we need is thrombin kits. What we do not need are these glitzy, flamboyant investigations. So, ladies and gentlemen, all I can say is we need to prioritize, we need to get our priorities correct, and let us answer the aspirations of the society and not get caught in this din of the glamour of medical technologies and clinical diagnostics. Thank you.